Hello, my name is Bacarius Batista. Student number is 22138252. Today I will be presenting my Sesame 2 case study for Health Variations 3. In this presentation, I will analyze the case of Mrs. Teresita Manalo, who is experiencing an embolic stroke resulting in decreased level consciousness, slurred speech, and left side weaknesses. I will discuss the ATE assessment findings, identify 4 high-priority nursing interventions with supporting evidence, and outline key nursing considerations for 3 prescribed medications: heparin IV infusion, metoprolol, and pantoprazole. To begin with ATE assessment, Mrs. Manalo's airway is documented as patent. However, her given decreased level of consciousness, her GCS is 12 out of 15, and slurred speech remains as high risk of airway obstruction due to impaired gag reflex and possible aspiration. Maintaining airway patency and readiness for suctioning is therefore critical. Evidence emphasizes that early airway protection and upright positioning are essential to prevent hypoxia and aspiration pneumonia in stroke patients. Moving to breathing, Mrs. Manalo's aspiration rate is 26 breaths per minute, and the oxygen saturation is 95% on 6 liters via Hudson mask. The elevated respiratory rate and shallow pattern indicate compensatory effect on secondary to neurological impairment of early hypoxia. Oxygen therapy should be titrated to maintain an oxygen level of 95% or over, or 95% or less, with continuous monitoring to avoid hyperoxia. According to Flute and Hogerveen, the ABCDE framework enables nurses to promptly identify and correct life-threatening abnormalities in breathing patterns. For circulation, her heart rate is 132 beats per minute, and blood pressure is 170 out of a 95, reflecting tachycardia and hypertension consistent with the acute stress response and potential intracranial pressure elevation. Peripheral coolness and mild edema suggests impaired perfusion, and clinical priority is to maintain adequate cerebral perfusion while preventing hemorrhagic conversion. Continuous ECG monitoring is required, as embolic stroke secondary to atrial fibrillation increase the risk of arrhythmia and further thromboembolism. Regarding disability, Mrs. Manalo's GCS is 12 out of 15. Indicates a moderate neurological deficit with left side weakness and facial droop. Neurological observation should be conducted every 50 minutes during the acute phase to identify deterioration. Early detection of a 2-point drop in GCS or new pupil changes must trigger a rapid response as recommended in the National Stroke Foundation guidelines. Finally, under exposure, Mrs. Manalo is afebrile with no visible injuries. Her intravenous access site in the left cubital fossa should be inspected for patency and signs of infiltration or infection. Ongoing temperature skin assessments help detect infections or pressure injury related to immobility. Overall, this ATE assessment highlights multiple clinical priorities: maintaining oxygenation, cerebral perfusion, and neurological stability, each guided by objective vital signs and evidence-based stroke care. 4 high-priority nursing interventions. The first priority intervention is to position Mrs. Manalo in a semi-Fowler's position. This posture promotes venous drainage from the brain, optimizes oxygenation, reduces aspiration risk in patients with dysphagia. Upright positioning is supported by Ashcraft, who emphasizes that it has a core component of stroke nursing care to enhance cerebral perfusion and airway protection. The second intervention is to conduct frequent neurological observations using the Glasgow-Coma scale and the NIH stroke scale. Early recognition of subtle changes enables timely escalations and prevention of secondary brain injury. Research indicates that structured neurological monitoring significantly improves outcome and reduces delay in initiating thrombolytic therapy. The third intervention is to maintain strict blood pressure and anticoagulation monitoring. As Mrs. Manalo is on a heparin infusion, frequent assessment of activated partial thromboplastin time is essential to balance therapeutic anticoagulation bleeding risk. Monitoring aligns with McElduff, who highlight the critical role of nurses in thrombolytic, and anticoagulant administration in acute stroke management. The fourth intervention is to implement aspiration precautions and ensure nutritional safety. Swallowing assessment by speech pathologist should precede oral intake, maintaining nil-belly mouth status until clearance reduces aspiration pneumonia risks. Providing oral hygiene and also supports comfort and infection prevention together. These four interventions prioritize airway protection, neurological stability, hemodynamic monitoring, and safety central aims in acute management of embolic stroke. Medication considerations. First medication is heparin. Heparin assessment. Baseline APTT, platelet count, and signs of active bleeding must be assessed before initiation. Ongoing monitoring of APTT every 6 hours ensures therapeutic range is maintained. Administration. Administer via infusion pump through a dedicated line to maintain accurate flow rates. Avoid IM injections to prevent hematoma formation. Side effects. The main risks are bleeding, heparin-induced thrombocytopenia, and hypersensitivity. Any unexpected bruising or drop in hemoglobin must be reported immediately. Timely adjustment of anticoagulant therapy after stroke prevents both thrombolic recurrence and hemorrhagic complications. Next medication is metoprolol. Assessment. Measure baseline heart rate, blood pressure, and ECG rhythm prior to administration. Hold the dose if heart rate is 60 beats per minute or systolic BP of 100. Assess dizziness or signs of heart block. Administer orally with food to minimize gastrointestinal discomfort. Do not crush sustained release tablets. Side effects. Common adverse effects include bradycardia, hypertension, and fatigue. Caution is required with patients with reduced cardiac output. Regular monitoring supports safe titration. Evidence from Ashcroft and McDuff highlight the role of beta blockers is controlling post-stroke hypertension and preventing cardiac complications. Pantoprazole. Evaluate for assessment. Evaluate for history of gastric ulcers or bleeding. Monitor for symptoms of reflux as well as magnesium and vitamin B12 levels during prolonged therapy. Administration. Administer before breakfast on an empty stomach to ensure maximal proton pump inhibition. Do not crush enteric-coated tablets. Side effects. Possible side effects include headache, diarrhea, long-term risk of hypomagnesemia, or osteoporosis. Wong reported that regular proton pump inhibitor use is associated with slightly increased risk of stroke in older adults. Those therapies should be regularly reviewed for necessity. Collectively, these medications considerations underscore the importance of continuous assessment, accurate administration, and vigilance for adverse reactions, key elements of safe and evidence-based pharmacological management in stroke care. Conclusion. In summary, Ms. Teresita Manala's case demonstrates the importance of structured ATE assessment to promptly identify and manage physiological derangements following the embolic stroke. The four nursing interventions, semi-fowler positioning, frequent neurological monitoring, and anticoagulation surveillance and aspiration precautions reflect core priorities in stroke care. The nursing considerations for heparin, metoprolol, and pantoprazole further emphasizes safe medication management grounded in evidence-based practice through historic and vigilant and guideline-informed nursing care with optimized outcomes and enhanced recovery for patients like Mrs. Manala. Thank you for listening to my presentation. These are my references for images used.